Well, good morning, everyone. Out of respect to our presenters' time, I'll just go ahead and get started with a brief introduction, and I'll turn it over to my colleague, Maria. So thank you for coming this morning. My name is Aisha Dixon. I'm the director of the UCLA Emeriti Retirees Relations Center, and we're so lucky and so glad to have this presentation for you. We will be recording it, so if you have to leave a little early or you want to share this with your friends, I will post in the chat the link to our YouTube channel because it'll be uploaded hopefully later today. Besides that, just some housekeeping. I'm going to make sure everyone is muted right now so that there's no rogue washing machine or laundry or street sweeper outside. We will allow you to unmute yourself once we get to the Q&A section. So let me go ahead and do that. And then Maria, go ahead and take it away to introduce our speaker, please.
I also wanted to say good morning to everyone and thank you so much for coming to our presentation today. And we're very fortunate to have with us Michael Mckinley, who is a staff pharmacist in the UCLA Health Department, and he's been working in pharmacy since 2008. He's got his Doctor of Pharmacy from UCSD and his Bachelor of Science in Biology from Loyola Marymount. And he will be talking to us today about all the ins and outs of Medicare and how it interacts with your prescriptions and all that good stuff. So whenever you're ready, Michael.
All right, I will go ahead and share my screen here so we can go ahead and get started. Hi, everyone. Thank you for joining us today on this lovely I think it's still cloudy outside, Friday afternoon or morning. I wish it was afternoon. See where my head's at already. But I appreciate having the time to go over this with you. I've worked in pharmacy for many years and it's ever changing. So, we'll go ahead and jump right into it. And I hope that this is informative and everyone learned something from this meeting. So just like Maria said, we'll be going over Medicare with a highlighted focus on our Medicare Part D or drug coverage, and also Medicare Advantage plans because they do cover medications as well. Just a small disclaimer, what is presented here is not a consultation of what decision you should make on your healthcare, but an informative session to allow you to use the necessary tools to best choose your own Medicare coverage. I cannot enforce enough that doing research before choosing your Medicare coverage is the most important part because it will then choose your benefits for at least the next year. Okay, just like Maria said, my name is Michael Mckinley. I came from UCSD Skaggs School of Pharmacy. I've been in pharmacy since 2008. I've been a pharmacist since 2015. I worked at CVS as an emerging leader and district leader for a few years prior to coming over here to UCLA as a staff pharmacist last year. Little personal note, I'm from LA, grew up, still live in the same neighborhood I lived in, really branched out all the way down to San Diego. But I'm just really a homebody, family, love my dog. So just a little bit about me before we jump into everything. A little bit about UCLA, just to let you guys know, our outpatient system is made up of 5 pharmacies. We service hospital patients, specialty patients, transplant patients, and also retail patients. We offer mail-out services. We work in collaboration with many prescribers on specialty and oncology medications. And we also, at one of our pharmacies, provide immunization. So if you guys are ever here on campus or your doctors are on campus, come by, find me, pop by, say hi. Or if you're ever interested in utilizing our services, you can always give us a call. Just a little bit of an agenda to tee it up. So we're going to go over the basic information on the branches of Medicare. So Part A, Part B, the differences of drug coverage, how Medicare Part D itself works, what are some of the Medicare Part D coverage rules and some limitations that they've put in place for all patients to ensure, proper use of medications and safety. Part D eligibility and enrollment process, extra help with Part D costs if you qualify, and probably what everybody is most interested is how do I look at different plans and how do I choose the right one for me? For everyone, you will have your own, medical background, and everyone's so unique in what they need from Medicare. So that's kind of the best thing is how can we find out to get the most out of our own Medicare plans? Okay, so first off, who is eligible? So for most people, it is just if you're 65 or over. That is the bulk of the people who make up Medicare. That being said, there are some other groups of patients that we have eligible for Medicare, and many of them I deal with as I do work with transplant patients quite often. So if you're younger than 65, if you have a disability greater than 24 months, meaning you end up with CHF and end up needing a heart transplant, you have cystic fibrosis from another autoimmune disease and need a lung transplant. If they have a special rule for ALS, if you're for children under 20, where they can bypass that 24 months. And then also anyone with end-stage renal disease requiring dialysis or a transplant is also eligible for Medicare. Though everyone here, everyone on the list above is eligible for Medicare, you must be a U.S. resident, or if you're not a U.S., or you also must be a U.S. citizen or lawfully admitted for permanent residence for greater than 5 years to be eligible for Medicare. So there are several branches of Medicare. So most of you have probably heard of these, but just to kind of make sure we all know what they're used for, we have Medicare Part A, which is strictly our inpatient or hospital coverage use of Medicare. We then have also Medicare Part B, which is our outpatient and medical coverage. So those cover, our outpatient doctor visits. It covers most immunizations, medical equipment, including diabetic testing supplies, and also certain medications. We have Part C, an alternative grouping of Medicare coverages, which means that we'll go into it more later, but basically if we want Part C, they're called our Medicare Advantage plans, and we are grouping all A, B, and D, so outpatient, inpatient, and drug coverage into one lump sum plan. And then lastly, we have Part D, which is our drug coverage. And then, we'll talk a little bit about Medicare versus Medicaid. Are we eligible for both? And, the easy answer is yes, but it is for very specific populations. So for Medicare Part A, for most of us, we will have free premiums that come with Part A. We will be enrolled in it once we're over 65. We have a deductible that would be $1,484. So that's an annual deductible. And then we also have our inpatient costs, since that's what it's covering, our hospital stays. And for every day 1 through 60 in the hospital, you do not pay anything after your deductible. And days 61 through 90, you pay in $371 per day. Now, in parentheses there, we see benefit period. Now, the main question that might pop in your head, what do I mean by benefit period? A benefit period is your hospital stay plus any stay that we have in a rehab or skilled nursing facility. To move from one benefit period to a second benefit period, we must have at least 60 consecutive days of not being admitted in the hospital or in a skilled nursing facility. So if I left the hospital today on May 7th and I was a Medicare patient, I would still be within the same benefit period if I came back to the hospital before July 6th, because that would fall within the 60 days of not being out of the hospital or out of a skilled nursing facility at home. So that is what encompasses our benefit period. That is a very important information, because even if we're only in the hospital for a week this time, if we come back and are in the hospital 5 weeks, we will get to that 61-day mark much quicker if we're in the same benefit period. And that means a lot for our pocketbook. we have Medicare Part B, which is our outpatient setting medical insurance. It is a $148.50 monthly premium, typically. Now, if you're someone who is over 65 and still working or receiving, a high amount of income, still that premium can be higher. So that premium is based off of your income at the time, but the lowest amount that you would pay is $148.50. So then we also want to know what is our out-of-pocket cost for our Medicare Part B, and that is we do 20% of all medically approved services. This does not include our deductible, which this year is $203. That deductible does change from year to year, and it is, made by CMS and the government. Our preventative services are covered at 100% typically. So your once annual checkup, if it's just your regular checkup, would be one of those services. Our immunizations, like the flu shot, would be covered at 100% coverage. And for all specific services and how much they would cost, then we would go to Medicare.gov for a complete list of services that you would be eligible for. We will go to Medicare.gov, the actual website, because this is where the bulk of your information to get is found. And we'll go there and explore it a little bit later on when it comes specifically to the drug coverage, but I will walk you to the home page so you do know how to get there and navigate it. So next we have Medicare Part D, which is, like I said before, is our drug coverage. So there are premiums associated with Medicare Part D in addition to your Medicare A and B coverage. We do have to enroll in this separately. So, if you just have Medicare A and B, it will not cover drugs with the exception of the immunizations that we've talked about, some of them. So that's flu shot, pneumonia, tetanus, not your shingle shot, which everyone needs, that comes through your Part D coverage. And then, you also can get through your Part B, it will cover your, if you have any transplant medications, it will cover some oncology medications, as well as nebulizer treatments, if we do use a nebulizer for either COPD or asthma. But we will go more into Part D and the ins and outs of it in the second part of in the bulk of the presentation. Next, we also have Medicare Advantage plans. So this is also known as Medicare Part C. So like I said before, this is combining all of our Medicare coverage into one plan, HMO or PPO. And this is through private health insurance companies. For example, some of you might have heard of Humana. Some people have heard of Scan or Express Scripts. These are ones who do combine all our Medicare coverage into one. This may work for some people, but the traditional A, B, and D coverage may be more beneficial to others. So definitely do your research before just jumping into a plan, because like I said, you'll be stuck in it for the next year, and it can make your life very difficult, especially if we're switching from an Advantage plan to regular Medicare back and forth, since not all doctors accept all of them, okay? And then the premiums vary on your coverage. So this is in addition to your Medicare Part B premium, and we will go through, how the premiums run and how we can choose our plan and what they cover later on. And if you join a Medicare Advantage plan, you cannot also get Medicare Part D. Your prescription drug coverage is built into your Advantage plan, so there is no need to get both, so you aren't allowed to get both. Another thing people have is called Medigap or Medicare Supplemental plans. This is something I encounter very often when I am at work. People tell me, oh, I have, my Medicare A and B and a supplemental plan. And they think that the supplemental plan will cover their drugs. Medicare supplemental plans do not cover medications, okay? You cannot have Medicare plans with Advantage plans, and they do not assist with drug copay. So if you have Part D and you have a copay, that is your copay. Your supplemental plan will not cover it. It is used to help cover if you are in, some type of a high coinsurance, and we want a Medigap plan to cover that high coinsurance for our outpatient settings. we would use it in that manner. And there are several plans that we can get, and they are all listed here. This is a chart that I found on the Medicare website of all the different Medigap plans. So if we can here, there's 1, 2, 3, 4, 5. There are 10 different plans, and it shows a check mark under each box of what they cover. The most common one I've seen people get is F. As you can see, that is the one with the most coverage, which is why people get that one. But it's a very simple chart. It is great to see everything in one place. So if Medigap or supplemental plans is something you want to choose for your outpatient or a hospital coverage, then you can add that in addition to your A and B. All right, so now we'll jump into our Medicare drug plans, AKA Medicare Part D as in dog. So we need to know what our eligibility is for this. So first of all, you must have either Part A or Part B. You do not need to have both, but you must have one. I have seen people with Part A that have a Medicare plan without Part B. It is possible. You must have also no other drug coverage. You know, if you have Medicare Part D, that is your medication drug coverage. You do not have any other drug coverage. The only time people can have dual drug coverage is if you are a Medi patient. And so we'll go into how people qualify for that later. But basically, that is an income-based qualification. If someone was on Medicaid before and are now transferring to Medicare, if they have a low enough income, they can qualify to have both coverages simultaneously to help lower their out-of-pocket costs. If someone does have Medicaid and enrolls in Medicare and they are still eligible for Medicaid because of their low income status, they will automatically have the assistance that we'll talk about later. They will be enrolled in it automatically and not need to qualify for it because they would have already qualified by being allowed to be a Medi patient. So Medicare Part D and Medicare Advantage plans open enrollment. So we need to know when we can enroll in these plans. Because if we don't enroll during the proper time, we can be assessed a premium or a fee if we do enroll outside of the open enrollment. So our initial enrollment is we can join a plan whenever we first become Medicare eligible at the age of 65. If you're above 65 and have already became Medicare eligible or missed our initial enrollment period, there is open enrollment for Medicare Part D drug plans from October 15th to December 7th, which then will take place and start on January 1st of the following year. For Medicare Advantage plans, the time for open enrollment is actually after the drug plans. So this is why it's kind of important to not go back and forth between an Advantage and drug plan, because we also don't want to see that month of December where we may have a lapse in drug coverage. That won't be good for anybody. But our time for open enrollment for that is from January 1st to March 31st. And like I said before, it is possible to enroll outside of these times, but you will be charged a fee for doing it. And so Medicare drug plans, what are some tips that we should follow, or why should I get a Medicare drug plan? First of all, we need to ask ourselves, do we take any prescription drugs? If we're 65, we're in great health, we don't take any prescription drugs, we may be asking ourselves, why would I get a drug plan and pay the premium for it if I don't need it? Or if I am on prescription drugs, which one will be the best one for me to choose? Okay. So we can have brand versus generic prescription drugs. Should you get extra protection from high drug costs? So meaning use a Medicare Part D drug plan, which will help lower brand drug costs. Sometimes prescription drugs are cheap enough for us to avoid, a Medicare Part D plan. But if we are on brand names, the prices of the medications skyrocket exponentially. And another thing we want to think about is, do I want to keep my expenses balanced? That'll be something you think about when you are choosing a drug plan, because there are many different coverage phases that we'll go through for Medicare Part D. And you'll see why this is a question that we need to address later on, because there are times of the year we may have higher costs to ourselves. Something else you want to think about is peace of mind. You know, we're not on any medications right now. I'm just starting Medicare. I'm 65. I'm healthy. I'm maybe on one medication that I found out CVS will give me for $12 for a month. I can handle that. But maybe I want peace of mind just in case something comes up over the next year. You never know what can happen. I may, you know, end up on a new medication that now costs several $100s a month. Maybe I'll get a low premium plan to just give me that peace of mind for this next year. And then, you know, another thing we want the convenience of everything in one place. And that's where we would then consider a Medicare Advantage plan. But like I said, do your own research on this. This is not for everyone, but it does provide some convenience. Okay, so Part D coverage requirements or rules mentioned on the first slide. So this is where I was talking about Medicare Part D does have some steps in place to attempt to help with patient safety, as well as require doctors to prove why they should be using an alternative therapy to what might be a more cost-effective therapy or maybe a first-line treatment option for a certain disease state. So an example of patient safety is pain medication safety check. Most insurance plans nowadays, if you are, you know, brand new to pain medications, you haven't been on pain medications in the past, you know, we get hospitalized with a broken wrist and we, you know, get out of the hospital and they give us an opioid of some type like Percocet or Narco or Vicodin or some of the names we may have heard of in the past. They will put a limit and force the doctor to either get approval for more medications or ask you to come back more often so that you aren't, you know, hooked to these medications that can be addictive. So they will put a quantity limit for your own safety of typically a week's supply, especially if you are taking in what's called an opioid medication for the first time. Another thing that they'll force is there's always a hard stop of any drug interactions with pain medications and high-risk medications like those for seizures or those that are blood thinners. There will be a hard stop to force the pharmacist to do their diligence, check your profile, and put in an override to say, yes, I feel that it is safe for this patient, Mike, to take this medication. There are prior authorizations in place where a doctor or sometimes a pharmacist will do what's called a prior authorization, fill out paperwork to say, you know, drug A is more important than drug B, which is the mainstay because, you know, Maria already took drug B and she failed therapy and drug A is now a better option for her. And then the insurance will approve it. That's also something that's similar with step therapy, you know, where we need to try the first mainstay of therapy before we go to the second line therapy, we would call it. So for example, to protect our heart, you know, from heart events, typically people will take a statin or a cholesterol medication. And some of them are more expensive than others, so the insurance will ask you to try the first mainstay therapy, typically one named Lipitor first, before you go to a second line therapy called Crestor. If they see that, they will allow it to go through. Okay. Part D also covers some vaccines. Like I said before, everyone here is typically looking out for the shingles vaccine. Nobody wants to get shingles. That is covered through your Part D coverage, not your Part B like the flu shot. So that's why it sometimes is important to have Part D because that vaccine runs $250 a shot and can be quite expensive. Okay, and then, you know, drugs received in the outpatient settings, hospital settings. So that is, like I said earlier, nebulizer solutions are items that are not covered by our Part D, but would by our Part B instead, also transplant or anti-rejection medications and some oncology medications. All right, so, you know, do I take any prescription drugs? We'll run through an example together. I've put a hyperlink here, but at the end of this presentation, I will show you how to get to the website itself. Okay, let's see here. And then I just want to make sure if Maria or someone can answer me, do we see the hyperlink of the Medicare drug plan now and not the PowerPoint. Can I get a thumbs up?
Yeah, we see the link, the PowerPoint's there, but.
Oh, so you're on the PowerPoint still. Okay. I just
Yeah.
didn't know if it would automatically jump. So let me switch screens here. Right, so all right, so now we should see the new screen of the Medicare the Medicare drug plan, okay?
Yes.
So you don't need to create an account. You can continue without logging in. So typically what I've done is I've gone through new to Medicare, question mark. We'll click on learn about our options. You'll put in your zip code. So I'll put in UCLA zip code. So our plans will be specific based on those zip codes. It will ask us, do we want to go the original Medicare coverage or to our Medicare Advantage plan? So we will start with the original Medicare coverage because we want to look at the Part D plans. I'll click on that. So it will let you choose if you want to get additional coverage. So original Medicare is your Part A and B. So if you see here, those are checked off. I will check off, I also want Part D, and it will show Part D is checked off. And if we wanted to, we could check off the Medicare supplement plan, the Medigap, but we're going to try to keep it a little simpler for right now, okay? We're going to scroll down and we're going to look at plans. And then it's going to ask us, do I get help with my drug costs from any of these other programs? I'm going to say I don't get any help right now from these programs. If you do, you would be aware of this, knowing that you either got supplemental income, Medicare savings programs from low income. If you're not sure, you can always go through not sure, because we are just kind of doing an example to see what the drug coverage are for us. Do I want to see my drug costs when I compare plans? Of course, that's why we're here. I use a retail pharmacy. So let's see here, what drugs are we on? I'm going to come up with some easy ones that are quite common. So we will do metformin for our blood sugars. I'm going to add it. It asks how many do we take a month. I'm just going to leave it like that. You can do that specifically for whatever medication you're on. We'll add another drug called Eliquis, which is a common blood thinner used nowadays for anyone going through a sometimes a hip or knee replacement surgery, or if you end up with AFib or a blood clot. So since I see that quite often, I will add it on as well. Let's add on a common blood pressure medication, maybe called Losartan. Everybody may recognize that for better or for worse from the news over the past couple years. And we'll add it to our drug list. And so let's say this is all the medications I'm taking. I can click, I'm done adding my drugs. Now we can put our pharmacies. We can add our pharmacies in here. So let's go here. I'll put CVS because I'm sure some of us out there have been in a CVS once or twice. They're just down the street from us. So we'll just select one that I know is quite large. Oops, why did it go back? Sorry, accidentally clicked back. We will now also add in, just for my benefit, UCLA pharmacies, and we will choose, one of our mail out pharmacies here where we mail out to patients right there. And we'll click done. So I will compare drugs between pharmacies and it starts to list them. We can see over here, we can sort by plans by many different options here. And so we can have lowest premium, lowest deductible, or lowest drug cost and premium, meaning most likely our lowest total monthly cost of medications. Okay, so from there, we can scroll down and we can select multiple plans and compare them. So let's click into one just to see what it looks like. So SilverScript, quite common plan I see all the time. We have a monthly premium of $29.50. So that would be in addition to your Medicare A and B coverage of $148.50. Okay. It says our yearly drug cost plus premium will be about $700. And we do have a $250 deductible. Okay. So click on plan details and it will break it down for us how it looks. So overview, like we said, premium $29.50 deductible. We have 3 coverage phases. like I mentioned earlier, I'll talk about them now. And so during the initial coverage phase, so this is prior to a gap coverage. So for everybody, I have the price listed later on in the slideshow. I believe it's about between 4,000 and 6,000. It changes every year for Medicare of what your initial coverage phase is, where you pay a copay on your medications. And this is what the copay would be: $0 for our preferred generics, $5 for regular generics, $35 for brand, and then a co-insurance of percentages for drugs that are not on our formulary, okay? We then would jump, after we get past the initial coverage phase, so if you have high cost medications or on many medications, you may find yourself eventually entering the gap, and that can happen at all times of year. I've seen someone enter the gap in March. I've seen someone enter the gap in November. I have seen people never enter the gap. The gap is a point where we then pay 25% of our total drug cost. Okay, so you'll notice you will go from your normal $35 copay, and it will jump up. And when we look further down, we will see what those costs would be to us. And then once we reach the other end of our gap, a predetermined dollar amount that has been determined by CMS or Medicare, our copays will jump down to either $3.70 for generic drugs, or 5%, or $9.20 or 5%, whichever costs more. Okay. We see here the pharmacies. My UCLA one is a in-network pharmacy. Our CVS one is preferred. So there might be a slight difference in copays. You would have to see each span specifically on what the difference would be. So we can scroll down. We see here UCLA level 4 pharmacy. Here's our retail drug cost. Just for if you guys are ever curious, this is our cost before our deductible. So our deductible, we pay the full amount, remember. Cost after deductible, which is our $250, is $47. So this number here for our Eliquis is $527 before the end of our deductible is not entirely accurate, because you'll only get charged full price for the $250 of your deductible, then plus your copay. So it would be $297 to get through your deductible. But your normal copay would then be $47.5 and $350. And then once we hit our gap, you're paying 25%. So you say, Mike, but why did my drug costs drop on these two generics? Because they are that cheap, and because 25% is less than your normal copay, they're only charging you the 25%. And then here we have cost after coverage gap, also known as catastrophic, which you can see $26.38, because that is, the 5% that we have to pay on that medication. We will then see, broken down by time period, our cost of medications every month. So according to this chart here, we will never get to our gap coverage. It'll all be our regular coverage because it is June, and we won't reach the gap because there's only 6 months in the year, and it resets in January. We also see here, due to CVS being our preferred in-network pharmacy, we see lower copays. $5 for UCLA, $0 for our generics here, and then $35 for our Eliquis from CVS versus $47. Okay. And then it breaks down how much we would do every month. So $285 the first month and $35 thereafter versus $305 and $55 thereafter. So we're looking at, saving about $200 by going to CVS. So $844 for the year at UCLA versus $701 at CVS. You can also do this, compare Walgreens. You can compare your mom and pop pharmacies if you have any of those in your area that you still want to support the local business. If it's, you may see the different amounts that you may be charged for using out-of-network pharmacies. Okay. Down here, we also have drug information about what tier they fall under. Higher the tier, the higher the drug cost. It will tell us if they require a prior authorization, yes or no. It will tell us if they require a step therapy, meaning this is not the first line choice, yes or no. And it also has quantity limits, meaning Eliquis, you can't get more than a 30-day supply at a time, okay? And then this is just, once again, our list of drugs. We can edit, add things if we want to. If we are worried, if we have an extensive drug list and we are worried about the cost of them after running through this options, you can always talk to your pharmacist or your doctor about other options that may be cheaper so that you have a better idea of your total out-of-pocket costs. So I'm going to jump back to our PowerPoint here. And then, see here, I have more, some things in the chat here I want to check out. Okay, are there any out-of-pocket maximum of A, B, and D? And what is the downside of Medicare options? And then I'll go through some of these answers at the questions and answers at the end. I will use that as the first ones that we go through, okay? So remember, we did the example. I used some of these medications. If you have more, I'll add more to when we do the Medicare Advantage plan just to make it more interesting of, not all of us only have one or two medications. We're not that lucky sometimes. So we'll go through that together. So coverage phases, we went through them. Initial coverage is your copay after your deductible. Your coverage gap is your 25% of your drug costs until you spend $6,550. There is extra help available for those who qualify. And that is all done based off of income, so you can apply for that. It's called low income subsidy. I have a slide on that in a second. Catastrophic phase was when we reach the other side of our $6,500 donut hole. And then supplemental plans, like I said before, do not cover our drug prescription expenses. So extra help, it's also known as low income subsidy. There is extra help available for patients with low income. So like I said before, if already enrolled in your state Medicaid, if you're in California, it's also known as Medi-Cal. You do not need to apply for this. You will automatically be enrolled. There is a extra help portion on the website where then you can apply for this coverage. So what this coverage does help with, it does help with high cost medications becoming lower cost because we are not usually eligible for manufacturer copay cards, okay? So what does that mean? That means if my Eliquis during my gap coverage, my donut hole, as we call it, costs $230, and that's a little too expensive for me now. Unfortunately, they do have copay cards, and we may not be eligible for it. Every drug you actually have to look at individually. I believe Eliquis may be one of the lucky ones that do help us, but for most drugs, you are not eligible for copay programs. If you do have low income, you can always apply to the manufacturer directly for copay assistance. Times when I've seen this is if people are on specialty medications or oncology medications that run 20, 30 grand a month, and our income for the year is only 50 grand as the household or less, they have been able to get the drug directly from the manufacturer at little or no cost to them. And that is something that our specialty pharmacy always helps patients with, and as well as doctors' offices should know about these as well to help everyone out. Okay, so we have Medicare Advantage plans, aka Part C. So these provide all benefits including drug coverage, A and B coverage, and can be as an HMO, PPO, or fee-for-service plan. Special note, the fee-for-service plan does not include drug coverage. Our fee-for-service plan, there is a list of fees that are associated with all services, and you need to check if your doctor is enrolled in one of these. Most doctors' offices are not enrolled in these fee-for-service plans. They will be enrolled in an HMO or a PPO. There was a question that I'll address now that I do remember seeing. Why would we not want Part C? Reason why we may not want Part C is because if we have Part C and we get enrolled into what's called an HMO because they are cheaper than a PPO, any Medicare Part B drug coverage, so meaning your oncology medications, transplant medications, which can be very high cost, would not be covered by your Part B. It will now be covered by your drug benefit costs and will be most likely severely more expensive. That is not always the case, but I have seen is most often the case. I work with transplant patients every day. When I discharge them from the hospital, I do see quite a difference in cost to them when they have an HMO plan for their transplant medications. Instead of paying $0 through their Part B coverage every month, they're paying $55, $60, $70, sometimes more, because of they have to go through their Advantage plan because they have an HMO. That is, so that's why I say Medicare Advantage plans can be great and, for the most straightforward patients, but if you have some complications that might, or we're worried about, drug coverage through oncology, which is our outpatient Part B drugs, it can be more costly through one of these HMO or PPO plans. But like I said, every plan is so individualized right now, we would need to do our research through the link that we're going to go through to make sure we choose the one that's best for us. So just like I said, these are quite complex. Let's make sure we do our research. I will quickly run through an example just to show you guys how it looks, but I want to make it quicker because we are running out of time, and I do want to give ample opportunity for questions because I know we've ran through a lot of information together. Let's find here. Screen. I'll share the new screen here. So now we're back on this home screen, the screen that we were at before. What are we looking for? So before, remember, we chose drug plan. Now we're going to choose an Advantage plan. The same zip code. Actually, that's my home zip code. That's fine. We use my home zip code. I don't get any other help. Go next. Yes, I want to compare drug costs. Add a retail. Next. So let's do an expense. Let's do a, I'm going to do one drug that I see all the time that would be no cost through Medicare Part B, but would cost something through a Medicare Advantage plan, just to help kind of solidify the answer to the question I had earlier. So a patient who just run under a new transplant is getting Tacrolimus. Typically, I see 240 pills a month. So I'm just going to add that on for us to know. We also put on our cholesterol medication that most of us will probably be already on. You can put back on the Eliquis that we had before, just for comparison purposes. And then we're going to be done adding drugs. So pharmacies, we'll do, for this time, we'll do a mom and pop pharmacy that's near my neighborhood, and a CVS, just to compare some other ones, just to get an idea. And then we can search now and filter by many different options here. So we can search by, hey, if we really want to know about hearing and dental and vision more so, because that's all grouped into here now, we can sort by that. If we have a certain insurance that we've heard great about, or we want to go through Kaiser, we can sort by that to filter down to those. Okay, of course, we want to know what includes drug coverage. Okay. So it's filtering those. And then if we're curious, because star ratings, and we've done a lot of research and we care about how well these plans perform, we can search by that as well. Okay. So we can scroll down, we can see here, we'll just do Central Healthcare Medicare Plan. We have a $0 monthly premium. We still have our $150 standard B premium. It has our yearly drug costs and premium. And then we have no deductible for health plan, and we have a maximum service that we would pay for in network here. I know that was a question earlier. We will, have to address the Part B question for that, but for Part C, it does show that for you. I know that is something that we typically do see with our HMOs and PPOs. And for Part C, it does include it as well because it is an HMO or a PPO. So we can look at our plan details really quickly. So like we said, zero deductible, great. This is our estimated yearly costs that we have, and then our maximum we pay for healthcare services in network. Breaks it down, doctor visits, specialist visits, says limits apply. It needs prior approval because it's an HMO. That's why the limits are there. It's not a PPO. Same thing for all of our diagnostics and labs. We have our copays here. Emergency visits, $50. So there's a lot of information here that is important. We get ambulance, we call 911, we fell and we hurt our knee, we broke a bone, we can't get up, no one can take us to the hospital. Ambulance. Copays for all different types of services here. There's so much information. We could have 2 hours just on a Medigap, going through one Medigap coverage. There's some fitness benefits. Sometimes people get reimbursed for certain or discounts on coverages at gyms. Telehealth. I guess some plans have benefits for food and meal preps, but going back down to look at our copays, I'm going to just jump straight to the other plans. So we're lucky here. This plan has $0 for our Tacrolimus. Great. Like I said before, some plans I've seen with $55 or more, but this one is great. Maybe you weren't expecting to have a transplant and it was a last second thing in your plan. You didn't realize your Tacrolimus costs more, but for this one, unfortunately, it doesn't show what my reasoning of getting not getting an Advantage plan. But here we go. We have after deductible, which we don't have a deductible, our costs of drugs. And this is at CVS because it's our standard in-network pharmacy. Plaza West, also standard in-network pharmacy. Our costs. We still have a coverage gap with our Advantage plan in our catastrophic coverage. And it can break down your monthly cost for drugs. Okay? Shows us our tiers. It does say Tacrolimus needs a prior authorization. So what does that mean? That means if you have a Tacrolimus medication, you switch to this plan because you just turned 65, doctor's gonna have to fill out some paperwork to get it covered. It will get covered because it is a life-saving medication, but it will need the doctor to do the paperwork, and that can take a couple of business days. So it's just some things to keep in mind with those. Part B drugs, chemotherapy drugs, 20% coinsurance, something to keep in mind. Okay, this might be a reason that might steer us away from it. This could be cheaper through our Part B. Okay, and then before we jump back to our slides, I'm going just to, this is the Medicare.gov homepage. You can search here. You can find plans, get started, find providers, want a new plan. Or if you're just interested in finding out about things, there are lots of links here. So your Medicare costs, I'm going to click on that real quick. I'm going to click on the Part A costs because I did see an out-of-pocket maximum question. Okay. I'm going to see if I can find it here. Right. But I believe typically there is no out-of-pocket maximum. You just pay the co-insurance. Let's see here. Yeah, so for me, from what I saw during my original research on this, you can get lower costs if you are low income. Part A premiums are typically free if you are 65 and qualify for it this way. If not, you can buy it for premiums down here. But there is no cost, no copays during those first 60 days. And there is a co-insurance between 61 days and 90. But I do know the 90 days, there is a higher cost associated with it. I'm trying to see if I can find you guys that out-of-pocket maximum here. So, all right, so it does not look for like there is an out-of-pocket maximum here. If you see after day 91 and above, it's $742 of co-insurance. So you're not being charged the full amount, but you will have a co-insurance of $750. That is strictly for your hospital coverage, okay? All right, and then let me just jump back to the slideshow, and then I will go through these questions here. share. Okay. And then, like I said, here are my references. Go to Medicare.gov. You can have MedicareInteractive.org as well. That helps choose all the plans for you. And we will go to the questions now. Let's see what we got here.
If it's easier, I can read the questions for you.
I can get it now. The harder part was during the slideshow because I could only see the slideshow and a little notification at the top. So
Okay.
if I don't know if you were reading them as we went, did you see one that was asked more commonly so I can hit that one first?
Yeah, I was gonna try to do the common ones. Is there a downside for the Medicare Advantage option?
So the downside would be if you need a Medicare Part B coverage drug, there could be some downside to that. You would also have to, it depends on the plan you enroll in. You may have higher premiums than your Medicare Part B coverage, and you also want to look at your total out-of-pocket maximum. As you saw with the Advantage plan, that was available to see, and there is an out-of-pocket maximum associated for your outpatient coverages with B, and then the Advantage plan does A as well. So you want to kind of compare the two on what the pros and cons would be. The biggest issue I could see coming in is if we know we will be needing oncology treatment. That's typically for that or a lung transplant is the times when I've seen B be more helpful than an Advantage plan.
Okay, so I'm gonna ask the general questions. I will tell everyone that we do have a healthcare facilitator for some of these more specific personal questions. I'm gonna put in the chat Bridget Sheehan Watanabe. She is the UCLA healthcare facilitator. She works with all retirees, employees, and their covered dependents. So for some of these very specific questions, I'm gonna defer you to email Bridget and she can definitely help you answer those questions. I'm gonna put that in the chat. But for another general question is, if you are on Medicare Advantage and you travel in US and out of the country, is there a coverage issue for
So
foreign travel?
that is going to be plan specific. Some of them will have some assistance with that. Most of them, I will assume, will have assistance with that because I do know that, you know, you guys probably worked hard. You want to spend some time traveling. That's a big question. We don't want to get stuck somewhere. So, you know, going back in, you know, my history, my grandfather had his gallbladder removed in Australia. They had to get off a cruise and he was able to get coverage through his insurance plan. But it will be plan specific on how much you get. If you do not get coverage and you may have to pay more out of pocket and resubmit it manually to the plan.
Okay, so I'm going to also put another thing in the chat because some of these questions I see familiar from when we had our open enrollment presentation. So every year around October, our office works with the Campus Human Resources and the retirement counselors to do open enrollment questions. So some of those we still have archived on our website. So you can check out that. It's also in the chat. But I will, again, defer the more specific questions to Bridget. You have her information there, and maybe you might also find some information on our open enrollment section. But I will go ahead and open it up for questions. So we only have a few minutes, but feel free to unmute yourself, raise your hand, or use your little icon thing if you have a question that you want to ask.
So I'm going to hit Mark's question real quick. Part D apply to injectables at doctor's office. The answer is it depends. If it is covered through your Part B, the doctor will do it. If it is covered through Part D, they will send it to the pharmacy. And it does go both ways. They will not be available either way. So that if the doctor cannot bill Part B for it, he will send it to the pharmacy.
Okay.
This is often why you see shingles now sent to the pharmacy, or other injectables like Humira you might see commercials for sent to the pharmacy because the doctors can't bill for it.
What about the one that, are there any out-of-pocket maximums for Medicare Part A, B, and D?
So A we addressed. That was the I did not see an out-of-pocket maximum, but there is a 742 coinsurance after each day at 91. Part B, let's see here. Part B, it looks like it's just straight 20%, and that's really not the more expensive one. Part A would be the most expensive. Part B is just your outpatient ones. I'm checking it on right here on the detailed as we speak. Part D, there is no out-of-pocket maximum. You have, once you hit that coverage gap, you then go to the catastrophic coverage where you pay low copays. So I do know Part D, there is no out-of-pocket maximum. And then, yeah, I do not see out-of-pocket maximums listed for any of the 3 parts, only for Part C.
Do you know the one about, so I have my son on the plan, I turned 65 in July. What happens with my son's coverage?
So that you would have to ask your benefits office specifically if you have to do COBRA coverage, if you have to pay separately for your son on the plan. I don't know how that would specifically work. If you're still working for the company, it would probably still be able to pay for your son to be on it. But if you're not working for the company anymore and you're using COBRA, it's really a benefits office question. I'm sure there is a way around it. I just don't know the answer.
And I think that is under the open enrollment section, but Bridget, again, the healthcare facilitator, will be able to answer that. There are some plans, you'll have to go to a different plan, I believe, but she's the expert. So reach out to Bridget. So we have a couple more minutes. If you want to unmute and ask a question, let's go ahead and do that now. Raise your hand. So I will be getting the slides from Michael, and I'll send out a follow-up so you can watch this presentation again or look at the slides and share them with friends. Again, it'll be posted to our YouTube channel. Any other questions? This is a lot to take in. So I know Medicare is a beast. So to have Michael break it down for us is great. And maybe we can have another series closer to open enrollment so that people can kind of make their decision. It's definitely difficult as a retiree when you're picking these new medical plans. And we do work closely with human resources to have these open enrollment workshops every single fall so that you know what the changes are, which programs are changing their premiums and things like that. But less of me talking and more of you. So any other questions? Okay. So this one we get quite a bit. So if you are employed and still work at UCLA, you are covered, yes. The thing that changes is if you move out of state, there becomes VIA benefits. So VIA benefits is the out of state, I guess, insurance, that's the word I'm looking for. It's an insurance website that you can pick your plan, and UC will cover up to, I believe, I want to say $2,000, don't quote me on the amount, but they'll pay you a cost to pick your plan out of state, if that makes sense. Okay. All right, last chance. Any questions? Okay.
All right, if I can just leave you guys with one more thing is, if you have a pharmacist you trust and you are switching Medicare plans, or maybe curious about why your drugs cost so much and want to know alternatives, they can help you quickly. If you make a phone call, hey, what's an alternative treatment that I could talk to my doctor about? We can help you with that. Very quick and easy. For something that's specific to why does this cost more than this, that is for your drug, your Part D drug coverage to address, or you can go online and see it there. But if you are worried about your drug coverage next year and are starting a new medication and it's too expensive and want alternatives, don't hesitate to call that pharmacist that you trust with your medications.
Great, thank you. So have a great morning, everyone. I'll get the slides to you hopefully later today. If not, definitely on Monday. It takes a while to upload these videos to YouTube. So thank you, everyone. Have a great weekend. Happy Mother's Day to those who are mothers and everyone else. So
Thank you, Michael.
Thank you, guys. Thank you all for joining.
Yeah, thank you so much.